There is something happening in Japan that most people in the Western world have never been told about. Something that becomes more obvious the longer you spend time observing the daily lives of elderly Japanese men and women. Not in hospitals, not in nursing facilities, but in their homes, in their gardens, in the narrow streets of rural towns and the busy sidewalks of older urban neighborhoods. You see a 92-year-old woman carrying 2 bags of groceries up a moderate incline without stopping to rest, without wincing, without reaching her hand to the back of her waist the way so many people in their 50s and 60s do instinctively, almost unconsciously, as if the lower back has become a permanent source of low-level suffering they have simply learned to live with. You see a 96-year-old man bending forward to pull weeds from a small vegetable plot. He maintains himself, straightening back up without difficulty, returning to the task again and again over the course of an hour. These are not exceptional individuals who have been selected for a documentary. These are ordinary people living ordinary lives. And what is extraordinary is precisely how ordinary this appears to be in Japan, how unremarkable it seems to those around them, how little it registers as something that needs to be explained. In the United States, lower back pain is the single leading cause of disability in adults over the age of 50. Not heart disease, not diabetes, not arthritis in the knees or the hips, the lower back. According to large-scale population surveys, more than 80% of American adults will experience significant lower back pain at some point in their lives, and for a substantial portion of those individuals, the pain becomes chronic. Something that shapes daily decisions, limits physical activity, disrupts sleep, and often leads to a cascade of medical interventions ranging from physical therapy to opioid prescriptions to surgical procedures that carry their own risks and complications. This is accepted as more or less inevitable. It is treated as a natural consequence of getting older, of having a spine that simply wears down under the pressure of decades of use. But if that were true, if spinal deterioration and lower back pain were simply the unavoidable result of aging, then the pattern should be roughly similar across all aging populations. And it is not. The gap between what is observed in Japan, particularly among the oldest segments of the population, and what is observed in the United States and across much of the Western world is not a small statistical variation. It is a consistent, documented, and largely unexplained divergence that points towards something far more specific than genetics or luck. I am a Japanese physician with over 40 years of clinical experience studying elderly patients in rural and urban Japan. My name is Dr. Kenji, and what I want to share with you in this video is not a theory. It is an observation built over decades of direct clinical contact with some of the oldest and healthiest individuals I have ever encountered, people who are 90, 95, 100 years old, and who do not describe lower back pain as part of their daily experience. Not because they have superior genes. Not because they have access to better medical care. In many cases, the rural elderly in Japan have had very limited access to modern orthopedic intervention. But because of something far more accessible and far more concrete. The specific foods they eat, the specific ways they move through their day, and the specific habits they have maintained without interruption across the entire course of their adult lives. This is what I intend to explain today. Not with vague lifestyle advice, not with recommendations to be more positive or to reduce stress, but with a precise biological account of what is actually happening inside the spine of an aging body, and why certain foods and certain daily behaviors either accelerate the deterioration of that structure or systematically protect it. What you are about to hear is grounded in the same medical science that informs orthopedic and geriatric practice, applied through the lens of what I have observed firsthand in a population that, by virtually every measure, ages better than any other on the planet. Before I continue, one request. If you find this information useful, and I believe you will, please consider subscribing to this channel. The information I share here is detailed, specific, and takes time to absorb. Subscribing means you will not miss what comes next. And if you are someone dealing with lower back pain, whether mild and occasional or chronic and disruptive, stay through to the end of this video, because the final section connects everything into a single coherent picture I believe you will find genuinely clarifying. Now let us begin. To understand why Japanese elders so rarely complain of lower back pain, you must first understand what lower back pain actually is at the biological level. Not what it feels like, but what is physically happening inside the body when it occurs. Because one of the most persistent obstacles to addressing this condition is that most people, and even many medical professionals in general practice, treat it as a single problem with a single cause. It is not. Chronic lower back pain in aging adults is almost always the result of at least 3 distinct biological mechanisms operating simultaneously, each one feeding into and amplifying the others. And unless you understand what those mechanisms are, it is impossible to understand why the habits and foods I am going to describe actually work. The first mechanism is intervertebral disc dehydration. The discs that sit between your vertebrae, the 23 of them that run from the base of your skull to your lower spine, are structures that function something like hydraulic cushions. They are composed primarily of water, held within a matrix of collagen and proteoglycans, and their ability to absorb mechanical load, distribute pressure evenly across the vertebral surfaces, and maintain the space between vertebrae that protects spinal nerves depends entirely on their hydration status. When those discs are well hydrated, they are resilient and effective. When they begin to lose water content, a process that begins in most people somewhere in their 30s and accelerates through the 40s and 50s, they become thinner, stiffer, and far less capable of absorbing the forces that pass through the spine during ordinary movement. The vertebrae begin to compress unevenly. Nerves that were previously protected by adequate disc height begin to experience pressure. The muscles around the spine, sensing instability, contract chronically in a protective response that itself becomes a source of pain and stiffness. This is disc degeneration, and it is the single most common structural finding in adults with chronic lower back pain. The second mechanism is sarcopenia of the paraspinal muscles, the progressive loss of the deep muscle mass that runs alongside the spine and is responsible for its postural stability. These are not the large superficial muscles that most people think of when they think about back muscles. They are small, deep, segmental muscles, the multifidus, the rotators, the semispinalis, that fire continuously throughout the day to maintain spinal alignment and distribute mechanical load across the entire vertebral column rather than concentrating it at specific vulnerable points. In a spine with healthy paraspinal musculature, the forces of gravity and movement are managed efficiently. In a spine where these muscles have atrophied, and they atrophy significantly in sedentary adults beginning well before old age, an enormous additional burden falls on the passive structures of the spine. The discs, the ligaments, the facet joints. These structures were not designed to bear that load independently, and they deteriorate more rapidly under it. Sarcopenia of the paraspinal muscles is not inevitable. It is a direct consequence of how a person uses or fails to use those muscles across the course of their adult life. And this is a point I will return to repeatedly, because it is central to everything I am going to explain. The third mechanism is systemic low-grade inflammation. This is perhaps the least understood of the three, and it is the one that most directly links diet to spinal health. Chronic inflammation, not the acute, localized inflammation that follows an injury, but the persistent, diffuse, low-level inflammatory state that is increasingly common in Western adults as they age, directly degrades the structural components of intervertebral discs. It does this by elevating specific inflammatory cytokines, particularly interleukin-6 and tumor necrosis factor alpha, that activate enzymes called matrix metalloproteinases. These enzymes break down the collagen matrix within the disc tissue. They accelerate the loss of proteoglycans, the molecules responsible for drawing and retaining water within the disc. And they create a biochemical environment in which disc cells begin to die at a faster rate than they can be replaced. The result is not simply inflammation in the conventional sense. It is a chemically driven acceleration of disc degeneration that compounds the mechanical and structural problems already caused by dehydration and muscle loss. These three mechanisms, disc dehydration, paraspinal sarcopenia, and systemic inflammation, operate on different timescales and through different pathways, but they share one critical feature. They are all modifiable, not by surgery, not by medication, not by any intervention that can be applied once a problem has already reached an advanced stage. They are modifiable by behaviors that are sustained consistently over time, by what a person eats, by how a person moves, and by what happens to the spine during the hours of sleep. This is the medical framework through which everything I am about to describe must be understood. Keep it in your mind as I walk you through each individual factor, because the power of what I am going to explain lies not in any single item but in how all of them address these three biological mechanisms simultaneously. Let me begin with something that most Western observers notice almost immediately when they spend time in traditional Japanese households, and then promptly misinterpret. The floors of traditional Japanese homes are designed for living at ground level. Meals are eaten at low tables. Social interaction happens on tatami mats. Rest happens on futons placed directly on the floor. And elderly Japanese men and women move between these floor-level positions and standing positions many times throughout the course of a single day. They sit cross-legged. They sit in seiza, a kneeling position with the body resting on the heels. They lower themselves to the ground and rise from it repeatedly, not as a form of exercise, not as a deliberate stretching routine, but simply as the ordinary mechanics of living their daily life. Western observers who see this often assume that it must be hard on elderly joints, that it must cause strain, that it represents a physical challenge these individuals are somehow enduring. The opposite is true. What these repeated transitions, floor to standing, standing to floor, kneeling to sitting, sitting to standing, are doing is something that no amount of time in a chair or on a sofa or in any fixed position furniture can replicate. They are activating the deep paraspinal stabilizers continuously throughout the day. Every time an individual lowers their body to the floor, the multifidus and the deeper layers of the erector spinae engage to control the descent, to maintain the alignment of the lumbar spine against the pull of gravity, and to coordinate the movement of the pelvis and the lower vertebrae in a way that distributes load across the entire spinal column. Every time they rise from the floor, the same muscles fire again, in the opposite direction against resistance, performing the kind of low-load, high-frequency muscular work that is precisely what those muscles require to maintain their mass, their strength, and their neuromuscular precision as the body ages. This matters enormously after age 50, because it is in this decade that the rate of paraspinal muscle atrophy begins to accelerate if it is not counteracted by consistent muscular demand. The research on sarcopenia is very clear on this point. Muscle tissue does not maintain itself passively. It requires mechanical loading, the experience of being called upon to work against resistance, to suppress the cellular signals that initiate atrophy. In the absence of that loading, muscle fibers are progressively replaced by connective tissue and fat. The deep spinal stabilizers are particularly vulnerable to this process because they are not engaged by most of the activities that constitute a sedentary or semi-sedentary daily life. Sitting in a chair, walking on flat surfaces, performing most routine household tasks. None of these activities demand enough from the paraspinal musculature to preserve it. The chair, in particular, is one of the most quietly damaging pieces of furniture ever normalized in human civilization. When the body is seated in a conventional chair, the deep spinal stabilizers are largely disengaged. The pelvis tilts posteriorly. The lumbar curve flattens or reverses. The load on the intervertebral discs, particularly at the L4, L5, and L5S1 levels, the most common sites of disc degeneration and herniation, actually increases relative to standing, because the disc is now bearing compressive force without the muscular support that distributes that force more evenly during upright posture. Japanese elders who live in traditional floor culture environments are doing something that a Western geriatric exercise program would struggle to replicate. They are engaging their deep spinal stabilizers hundreds of times per day, every day, for decades. Not in a gym, not in a physical therapy session, in the ordinary course of their daily life. The cumulative effect of this over 40 or 50 years is a paraspinal musculature that is substantially better preserved than that of age-matched individuals who have spent the same decades primarily in chairs. And a better preserved paraspinal musculature means less load on the passive structures of the spine, slower disc degeneration, and a dramatically lower likelihood of the chronic mechanical lower back pain that afflicts so many Western adults in their 60s, 70s, and beyond. There is one additional dimension to this that I want to address, because it is often overlooked in discussions of posture and spinal health. The floor-sitting positions used in traditional Japanese life, seiza in particular, but also cross-legged sitting on a cushion, require active hip flexor flexibility and active engagement of the gluteal muscles to maintain without discomfort. This matters because the gluteal muscles, particularly the gluteus maximus and gluteus medius, are primary stabilizers of the pelvis, and pelvic stability is foundational to lumbar spine health. When the pelvis is unstable, when the gluteal muscles are weak or poorly recruited, as they tend to become in people who sit in chairs for most of the day, the lumbar spine cannot maintain its natural curvature efficiently under load. The result is a progressive transfer of mechanical stress to the lumbar vertebrae and discs that accelerates the degeneration I described earlier. The daily practice of floor-level living maintains both hip flexibility and gluteal recruitment in a way that passive sitting in chairs actively suppresses. This is not a philosophical claim about the superiority of traditional lifestyles. It is a mechanical fact about how the human musculoskeletal system responds to the demands placed upon it across time. Now I want to turn to food, and specifically to something that is so common on the Japanese breakfast table that many elderly Japanese individuals would be surprised to learn that most people in the Western world have never tasted it, let alone consumed it daily. Natto is a fermented soybean preparation that has been part of the Japanese diet for over 1,000 years. It has a strong smell, a stringy, viscous texture, and a flavor that tends to require some acclimatization. It is not, by any standard, a food that appeals immediately to the Western palate. But from a nutritional standpoint, and specifically from the standpoint of spinal health in aging adults, it is one of the most remarkable foods that exists. Not because of its protein content, not because of its probiotics, but because of a single compound that it contains in concentrations that are essentially unmatched by any other common food source in the world. That compound is vitamin K2, in its -7 Malawian kwacha's form, menaquinone 7. And to understand why this matters specifically for the aging spine, you need to understand what vitamin K2 actually does in the body, because it is profoundly different from what most people assume vitamins do. Vitamin K2 is not primarily an antioxidant. It is not primarily an anti-inflammatory agent. It is a molecular signal, a biochemical instruction that directs where calcium goes within the body. Calcium, as most people know, is essential for bone density. What fewer people understand is that calcium does not automatically deposit itself in bone. The human body contains a sophisticated system of proteins, osteocalcin in bone tissue, matrix GLA protein in arterial walls and soft tissue, that determine where calcium is mineralized and where it is not. These proteins require vitamin K2 to be activated. Without adequate vitamin K2, osteocalcin in the bones remains in an unactivated, undercarboxylated state, and the calcium that should be incorporating into vertebral bone is instead free to deposit in soft tissues, in arterial walls, in the cartilaginous structures of joints and discs, where it does not belong and where its presence is actively harmful. This is not a theoretical concern. The undercarboxylation of osteocalcin, which is a direct measurable marker of vitamin K2 deficiency, is strongly associated with both reduced bone mineral density and with the calcification of soft tissues. In the context of the aging spine, this means two things. First, vertebral bone density is compromised. The vertebral bodies themselves become less dense, more susceptible to compression fractures under ordinary load, and less capable of providing the structural foundation that the intervertebral discs require to function correctly. Second, soft tissue calcification, including calcification of spinal ligaments and the outer annular layers of intervertebral discs, contributes directly to the stiffness, rigidity, and pain that characterize advanced lumbar degeneration. Vitamin K2 in adequate amounts activates the proteins that prevent both of these processes. It routes calcium into bone where it strengthens the vertebral structure, and it suppresses its deposition in the soft tissues where it would otherwise accumulate as the spine ages. The reason this matters, particularly after age 50, is straightforward. It is in this decade that bone remodeling begins to shift decisively in the direction of net loss. The processes that build bone slow down. The processes that break it down do not. In the absence of adequate vitamin K2, this shift is accelerated, and the consequences for vertebral density are significant. But there is another dimension that is almost never discussed in mainstream medical contexts, and it is one that I find particularly compelling given what I have observed clinically. Research on populations with high dietary vitamin K2 intake, and the Japanese population, largely because of natto consumption, has among the highest dietary vitamin K2 intake of any population in the world, consistently shows not only better bone density outcomes but better overall musculoskeletal integrity into advanced age. The mechanism is not fully elucidated, but the association between adequate K2 status and the preservation of spinal structure across the 8th, 9th, and 10th decades of life is one that deserves far more attention than it currently receives in Western preventive medicine. The near-total absence of vitamin K2 from Western diets is not an accident. Vitamin K2 in the -7 Malawian kwacha's form is produced almost exclusively through bacterial fermentation of soybeans in natto. Western dietary sources, fermented cheeses, egg yolks, some organ meats, contain modest amounts of K2 in the shorter-chain -4 Malawian Quatches form, which has a much shorter half-life in the blood and does not produce the same sustained elevation of K2 status that natto does. A single serving of natto provides enough -7 Malawian Quatches to maintain optimal K2 activity for several days. There is no comparable Western food. This is a genuine nutritional gap, and its consequences for bone and spinal health accumulate silently over decades before becoming visible in the form of compression fractures, advanced disc degeneration, and the chronic lower back pain that so many Western adults simply accept as inevitable. Let me now describe something that you can observe at the fish markets of almost any Japanese town, and that is as common in the home kitchens of elderly Japanese individuals as bread is in an American household. Small fish, whole small fish, eaten in their entirety, bones and all, are a fixture of the traditional Japanese diet in a way that has no real equivalent in Western eating habits. Sardines, in particular, and the closely related awashi, are consumed regularly by elderly Japanese individuals, often several times per week, prepared in ways that make the consumption of the bones completely natural. Simmered until soft, dried and eaten as a snack, ground into preparations that incorporate the entire fish. And this habit, which might seem like a minor dietary detail, turns out to be one of the most nutritionally efficient things a person concerned with spinal health could possibly do. Not because of any single component, but because of the specific combination of compounds that are delivered simultaneously when a whole small fish is consumed. The first of those compounds is calcium, but not calcium in the form of a supplement or calcium in the form of dairy, which comes with its own complex metabolic effects. The calcium in fish bones is calcium in a highly bioavailable hydroxyapatite form, the same mineral matrix that constitutes human bone. Research comparing calcium absorption from different dietary sources consistently shows that fish bone calcium has absorption characteristics that are at least as favorable as dairy calcium, and in some studies more so, particularly in individuals whose digestive function has changed with age. For the aging vertebral spine, which depends on adequate dietary calcium to maintain bone mineral density in the face of the net bone loss that accelerates after 50, this represents a meaningful and consistent source of the raw material that bone remodeling requires. The second compound is marine collagen, specifically, the precursors to type 2 and type X collagen that are found in abundance in the connective tissues of small fish consumed whole. Collagen is the primary structural protein of the intervertebral disc. The nucleus pulposus, the inner, water-retaining core of the disc, is predominantly water held within a collagen and proteoglycan matrix. The annulus fibrosus, the outer, fibrous ring that contains the nucleus and resists the mechanical forces that try to push the disc outward, is composed of highly organized collagen fibers arranged in precise lamellar layers. The integrity of both of these structures depends on continuous collagen synthesis and remodeling, a process that slows dramatically with age, not because the cellular machinery for collagen production disappears, but because the availability of dietary precursors declines, and because the biochemical environment created by chronic inflammation actively degrades collagen faster than it can be replaced. Dietary marine collagen precursors, hydroxyproline, glycine, proline, provide the raw materials that the cells within the disc use to maintain and rebuild its structural framework. This is not a supplement effect. This is baseline nutritional support for a tissue that is continuously being subjected to mechanical stress and requires continuous repair. The third compound is omega-3 fatty acids, specifically EPA and DHA. The long-chain marine omega-3s that are present in high concentrations in small fatty fish and that are almost entirely absent from the diets of most Western adults. The relevance of omega-3 fatty acids to lower back pain is not widely understood in the general public, but the mechanism is clear and well documented. EPA and DHA are precursors to a class of signaling molecules called resolvins and protectins, compounds that actively resolve inflammatory processes at the cellular level. They compete directly with arachidonic acid, the omega-6 fatty acid that is the precursor to pro-inflammatory prostaglandins and leukotrienes, for the same enzymatic pathways. When the ratio of omega-3 to omega-6 fatty acids in the diet is favorable, the resolution of inflammatory processes is efficient and complete. When the ratio is unfavorable, as it consistently is in Western diets, where omega-6 intake from vegetable oils and processed foods dramatically outpaces omega-3 intake, inflammatory processes tend to become persistent and self-sustaining, creating exactly the kind of low-grade systemic inflammation that I described earlier as one of the 3 primary drivers of lumbar disc degeneration. Japanese elders who consume small whole fish several times per week are not doing so because they have been told it is good for inflammation. They are doing so because it is part of a food culture that has been in place for generations. But the biological consequence of that habit, sustained across decades, is a consistently favorable omega-3 to omega-6 ratio that maintains an anti-inflammatory biochemical environment in the disc tissue specifically and throughout the body generally. This is one of the reasons why the spinal discs of elderly Japanese individuals who have maintained traditional dietary habits tend to show less advanced degeneration on imaging than age-matched Western counterparts, and why the clinical presentation of lower back pain, when it does occur, tends to be less severe and less disabling. There is one more aspect of small fish consumption that I want to address before moving on, because it speaks directly to one of the most common questions I receive from Western patients who are trying to understand how to translate these dietary observations into something they can actually practice. The specific species matter less than the principle. Small, whole, fatty fish consumed regularly, including the bones where possible, or in preparations where the bones have been softened enough to be eaten. Sardines canned in water with the bones included are an accessible and complete approximation of this. The omega-3 content, the calcium from the bones, and the collagen precursors from the connective tissue are all present. This is not an exotic or expensive food. It is one of the most affordable and nutritionally concentrated foods available in most Western grocery stores, and it is systematically underconsumed by precisely the population that would benefit most from it. Now I want to return to movement, specifically to a form of movement that is so embedded in the daily structure of Japanese life that it rarely registers as a health behavior at all, and that is for this reason almost never adequately captured when researchers try to measure what makes Japanese aging different. Walking, not power walking, not interval training, not any form of structured exercise, just walking but in a specific pattern with a specific frequency, and in a specific relationship to the daily routine that gives it a biological significance that occasional or recreational walking does not have. The elderly Japanese men and women I have observed most closely over the course of my clinical career walk in a way that is inseparable from the texture of their daily lives. They walk to the market in the morning. They walk to the community center. They walk to the temple. They walk to visit a neighbor. The distances are not long, typically between 10 and 30 minutes in each direction, and the pace is moderate, not strenuous. But the critical feature of this walking habit is its distribution throughout the day. It is not a single block of walking activity that takes place at a specific time and then ceases. It is a pattern of short, frequent ambulatory intervals that punctuate the day from morning to evening, separated by periods of rest or floor-based activity rather than by prolonged seated immobility. And this distribution pattern turns out to matter enormously for the biology of the intervertebral disc. The intervertebral disc is an avascular structure. This is a fact that is often mentioned in medical education and then not adequately reflected upon. The disc has no blood supply of its own. It receives its nutrients, oxygen, glucose, the building blocks of collagen and proteoglycans, not through a network of capillaries, but through a process of diffusion from the capillaries of the adjacent vertebral end plates. This diffusion process is driven by mechanical loading and unloading. When the disc is compressed under load, as it is during standing and walking, fluid and metabolic waste products are slowly expressed outward. When the disc is unloaded during rest, that fluid is drawn back in, carrying with it the dissolved nutrients that the disc cells require to survive and function. This cycle of compression and decompression is how the disc feeds itself. Without it, disc cells become hypoxic, metabolically stressed, and begin to undergo the degenerative changes that ultimately manifest as disc degeneration and lower back pain. Prolonged sitting interrupts this cycle in a particularly damaging way. As I mentioned earlier, seated posture actually increases compressive load on the lumbar discs relative to standing, particularly on the lowest discs L4, L5, and L5S1, which bear the greatest cumulative mechanical load throughout life. When this compressive load is sustained for hours without interruption, the disc is denied the alternating cycle of loading and unloading that drives nutritional diffusion. Disc cell metabolism becomes compromised. The synthesis of proteoglycans, the molecules responsible for the disc's water-retaining capacity, slows. The disc begins to lose its hydration more rapidly than normal, And this process, repeated day after day over years and decades, is one of the primary mechanisms driving the accelerated disc degeneration that is so characteristic of sedentary Western adults. The walking pattern of Japanese elders counteracts this by ensuring that the disc is never deprived of the mechanical stimulus it requires for nutritional exchange for extended periods. A 30-minute walk in the morning, followed by domestic activity, followed by an errand on foot in the early afternoon, followed by more movement in the evening. This pattern maintains adequate lumbar blood flow and disc diffusion across the entire waking day. The cumulative effect on disc hydration, and therefore on disc health and resilience, over decades of this pattern versus decades of prolonged daily sitting is dramatic. And importantly, the walking pace required to achieve this effect is not high. Research on disc hydration dynamics consistently shows that slow to moderate walking, the kind of walking that elderly individuals with no particular fitness orientation naturally perform, is sufficient to drive the nutritional diffusion cycle. The benefit is not in the intensity. It is in the regularity and the distribution across the day. I want to address now something that is consumed in Japan with a frequency and a consistency that is almost impossible to overstate, and that is so deeply embedded in the daily routine of elderly Japanese individuals that removing it would represent a more significant disruption to their day than removing a meal. Green tea is not a beverage in Japan the way coffee is a beverage in the United States. Something consumed once or twice in the morning as a ritual of waking. It is a continuous presence throughout the day. Multiple cups in the morning, more during the midday hours, more in the afternoon. Elderly Japanese individuals may consume 5, 6, 7, or more cups of green tea in the course of a single day, not because they have been told it is good for them, but because it is simply what one drinks, what has always been drunk in every social context at every point in the day. The specific compound in green tea that is most relevant to spinal health and to the reduction of chronic lower back pain is EGCG, or epigallocatechin gallate, the primary and most biologically active catechin in green tea. EGCG is one of the most extensively studied plant-derived compounds in the scientific literature, and its anti-inflammatory mechanisms are among the best characterized. But to understand why it is relevant specifically to the aging lumbar spine, I need to return briefly to the inflammatory cytokines I mentioned earlier, interleukin-6 and tumor necrosis factor alpha. These two molecules are central orchestrators of the inflammatory process that drives disc degeneration. IL-6 is produced by disc cells under mechanical stress and in response to the general systemic inflammatory environment of an aging body. It activates signaling pathways, most notably the NF-κB pathway, that upregulate the production of matrix metalloproteinases, the enzymes that break down the collagen and proteoglycan matrix of the disc. TNF-alpha operates through similar pathways and additionally promotes the apoptosis, the programmed cell death of nucleus pulposus cells, which are the cells responsible for maintaining the hydration and mechanical properties of the disc's inner core. The loss of these cells is one of the primary drivers of irreversible disc degeneration, because the disc has extremely limited regenerative capacity and the cells that are lost cannot be easily replaced. EGCG suppresses both of these cytokines through multiple independent mechanisms. It inhibits the activation of NF-κB directly. It reduces the expression of the genes that encode IL-6 and TNF-alpha. It suppresses the activity of the matrix metalloproteinases that these cytokines activate. And it does something additional that is particularly relevant after age 50. It activates autophagy in disc cells, a cellular cleaning process that removes damaged proteins and dysfunctional organelles and allows cells to continue functioning efficiently under the kind of chronic, low-level oxidative stress that accumulates in aging tissues. Research conducted specifically on nucleus pulposus cells exposed to EGCG has demonstrated direct inhibition of the degenerative signaling pathways that drive disc deterioration, not in theory, but in direct experimental models using the same cellular mechanisms that operate in the human lumbar disc. But here is the aspect of this that is most important to understand, and that is most frequently missed when people read about the benefits of green tea or EGCG in a general health context. The biological effect of EGCG on inflammatory markers is dose-dependent and concentration-dependent. A single cup of green tea produces a transient elevation of EGCG in the blood that rises and falls over the course of a few hours. This transient elevation produces a measurable but modest anti-inflammatory effect. What produces a sustained, clinically meaningful suppression of the inflammatory environment in disc tissue, the kind of effect that, maintained over years and decades, could plausibly account for the difference in disc health between populations is not occasional consumption. It is the consistent, throughout-the-day consumption pattern that characterizes elderly Japanese individuals. Multiple cups, beginning in the morning and continuing through the afternoon, maintaining a relatively stable blood concentration of EGCG across the waking hours. This is the pharmacological reality of green tea as an anti-inflammatory food. Its efficacy is determined not by whether you drink it, but by how often and how consistently you drink it. An adult who consumes 2 cups of green tea in the morning and nothing more for the rest of the day is getting a fraction of the biological exposure that a Japanese elder who drinks 6 or 7 cups throughout the course of the day is getting. The difference is not marginal. It is substantial enough, sustained across decades, to produce measurable differences in the inflammatory environment of disc tissue and in the rate of the degenerative changes that depend on that environment. This is why I describe the Japanese pattern of green tea consumption not as a habit but as a biological intervention, one that is so integrated into the texture of daily life that it requires no deliberate effort to maintain, and that produces cumulative anti-inflammatory effects on the spine that have no real equivalent in Western dietary patterns. The practical implication is straightforward. If you are over 50 and concerned about the health of your lumbar spine, the question is not whether to drink green tea. It is how to make green tea present throughout your day in the same way that other beverages are currently present. Not as an addition to a daily routine, but as a replacement for less beneficial beverages, distributed across morning, midday, and afternoon in a pattern that maintains a more sustained blood concentration of EGCG than 2 cups taken together in the morning could achieve. Let me now address something that is almost never discussed when Western physicians or health researchers analyze the Japanese longevity advantage. And that is something so basic, so universal, so apparently unworthy of investigation, that its significance has been overlooked in plain sight: what happens to the spine during the hours of sleep, and specifically how the surface on which a person sleeps affects the biology of spinal recovery during those hours. The traditional Japanese sleeping surface is the futon, a firm, low, floor-level sleeping arrangement that provides substantially less cushioning and substantially more spinal support than the modern Western mattress. Elderly Japanese individuals who have maintained traditional sleeping habits spend 7 or 8 hours each night on a surface that maintains the natural alignment of the spine, the lumbar curve, the thoracic curve, the cervical curve, without allowing the body to sink into a position of lumbar flexion or lateral deviation that the compressible foam and spring-based structures of Western mattresses often produce. And this matters because of a biological process that most people are completely unaware of, and that turns out to be one of the most important determinants of long-term disc health. I described earlier how the intervertebral disc feeds itself through a process of hydraulic diffusion driven by alternating compression and decompression. During sleep, during the hours when the body is horizontal and the gravitational compressive load on the lumbar discs is minimized, the disc undergoes its most significant rehydration. Fluid moves back into the disc from the surrounding tissue, and with it, the dissolved oxygen and nutrients that disc cells require. This is why most people are measurably taller in the morning than in the evening. The discs have rehydrated during sleep and recovered some of the height that was compressed out of them during the preceding day of upright activity. This nocturnal rehydration process is not incidental. It is the primary mechanism through which the disc partially recovers from the daily mechanical stresses placed upon it, and its efficiency determines, to a significant degree, how quickly or how slowly the disc degenerates over the years. The efficiency of this rehydration process depends on spinal alignment during sleep. When the spine is maintained in a position that closely approximates its neutral alignment during sleep, when the lumbar curve is supported, when the pelvis is not tilted into a position that compresses one side of the disc preferentially, the pressure differential between the disc and the surrounding tissue is distributed evenly, and fluid can move into the disc from all directions with equal efficiency. When the spine is allowed to sag into a position of exaggerated flexion or extension, which is what happens when the sleeping surface is too soft, when the body sinks into the material rather than being supported by it, the disc is compressed unevenly during the hours when it should be decompressing fully. The rehydration that should be occurring is partially blocked. Over the course of a night, this may seem trivial. Over the course of years, sleeping on a surface that consistently impairs nocturnal disc rehydration is a form of chronic, low-grade disc stress that compounds all of the other factors I have already described. Traditional Japanese sleeping surfaces, firm futons on the floor, maintain the kind of spinal alignment during sleep that optimizes nocturnal disc rehydration. The floor itself provides a limit to how deeply the body can sink, regardless of the compressibility of the futon. The result is a spine that, night after night, decade after decade, recovers as fully as its biological capacity allows from the demands placed upon it during the day. This is not a dramatic intervention. It is a quiet, continuous, nightly biological process that, sustained across 40 or 50 years, produces a cumulative difference in disc hydration status and structural integrity that becomes visible in the clinical outcomes of aging, in who develops severe disc degeneration and chronic lower back pain, and who does not. I want to be precise about what I am not claiming here. I am not claiming that sleeping on a hard floor is beneficial for all people in all circumstances. I am not suggesting that Western adults with existing lumbar pathology should abandon their mattresses tomorrow. The appropriate sleeping surface varies with body weight, with the presence or absence of existing structural pathology, and with the specific configuration of the individual spine. What I am drawing attention to is the direction of the relationship. The firmer and more supportive the sleeping surface within a reasonable range, the better the conditions for nocturnal spinal decompression and disc rehydration. The extremely soft, deeply compressible mattresses that have become standard in Western households tend to fall outside that reasonable range for many adults, and the consequence, quietly expressed over decades, is a disc that never fully recovers its hydration status during sleep, and that therefore degenerates more rapidly under the loads of subsequent days. This is the third and final habit I want to describe. And now I want to bring together everything I have discussed, not as a summary because this is not a moment for summary, but as an explanation of why these habits and foods, considered individually, are meaningful, but considered together, they constitute something fundamentally different. A systematic, comprehensive, and apparently unconscious management of all three of the biological mechanisms that drive lumbar disc degeneration and chronic lower back pain in the aging adult. Return to the three mechanisms I described at the beginning of this video. Intervertebral disc dehydration, paraspinal sarcopenia, systemic low-grade inflammation. Each of these operates through a different pathway. Each of them responds to a different category of intervention. And what is remarkable about the combination of habits and foods I have described is that each one addresses a different mechanism. Not redundantly, not overlappingly, but in a way that is genuinely complementary, covering the biological terrain of spinal degeneration with a comprehensiveness that no single intervention could achieve. The floor-sitting and floor-rising habits address paraspinal sarcopenia directly by demanding continuous, high-frequency engagement of the deep spinal stabilizers throughout the daily routine in a way that prevents the muscular atrophy that is otherwise almost inevitable in an aging sedentary spine. The walking habit addresses disc hydration and paraspinal function simultaneously by maintaining the mechanical loading and unloading cycle that drives nutritional diffusion into the disc, and by engaging the postural stabilizing system through varied terrain in a way that complements the muscular demands of floor-based activity. The natto and fermented soy habit addresses vertebral bone density and soft tissue calcification through the precise regulation of calcium metabolism that only adequate vitamin K2 can achieve, protecting the structural foundation upon which disc function depends. The small whole fish habit addresses disc hydration and anti-inflammatory status simultaneously, delivering collagen precursors that support the disc's structural matrix, calcium in a highly bioavailable form for vertebral bone, and omega-3 fatty acids that shift the systemic inflammatory environment in a direction that slows the chemically driven degradation of disc tissue. The green tea habit addresses the inflammatory mechanism at the molecular level, suppressing the specific cytokines and enzymes that drive the breakdown of the disc's collagen and proteoglycan matrix, and doing so continuously throughout the waking hours in a way that produces a sustained anti-inflammatory effect rather than the transient and insufficient effect of occasional consumption. And the firm sleeping surface habit addresses disc hydration at the nocturnal level, optimizing the conditions for the rehydration process that partially restores disc height and hydration each night, and that over decades determines whether the disc retains enough structural integrity to resist the compressive forces of the following day. Each of these 6 factors addresses a different piece of the same problem. Taken individually, each one contributes meaningfully. But what makes the traditional Japanese lifestyle, specifically as it is lived by the oldest and healthiest individuals I have studied, so effective at preventing the chronic lower back pain that devastates so many Western aging adults is not any one of these factors. It is the fact that all of them are present simultaneously, continuously, and have been present simultaneously and continuously for the entire adult lifetime of the individuals in question. The disc does not dehydrate significantly, because both the walking habit and the sleeping surface are optimizing hydration across the daily cycle. The paraspinal musculature does not atrophy significantly, because floor-level living and daily walking are continuously demanding its engagement. Systemic inflammation does not reach the chronic, low-grade state that drives disc degeneration, because the anti-inflammatory load of the diet, from omega-3s in fish, from EGCG in green tea, from the fermented compounds in natto and miso, is consistently present in amounts that suppress the specific inflammatory pathways relevant to disc tissue. And the vertebral bone that provides the structural platform for the discs remains dense enough, and the soft tissues around the spine remain free enough of pathological calcification, because vitamin K2 from daily natto consumption is directing calcium precisely where it needs to go. This is what I mean when I say that these habits work as a system. Not in the sense that each habit somehow amplifies the others in some mysterious way, but in the precise medical sense that each one is addressing a distinct biological mechanism that the others are not fully addressing, and that the simultaneous management of all of these mechanisms produces an outcome that is qualitatively different from the management of any one of them in isolation. A Western adult who begins eating sardines twice a week but continues to sit in a chair for 10 hours a day, continues to sleep on an excessively soft mattress, and continues to have no dietary source of vitamin K2 will receive some benefit from the omega-3s and collagen precursors in the fish. But that benefit will be operating against a background of continued paraspinal atrophy, continued nocturnal disc decompression impairment, and continued vertebral bone loss, and the partial intervention will produce only a partial result. The observation that deserves to sit with you as I conclude this section of the video is this. The Japanese elders who age past 90 without lower back pain have not done something dramatic or difficult. They have not followed a medically prescribed protocol. They have not taken supplements or undergone treatments. They have lived in the same way they have always